Hello, and welcome to One World, One Health, where we take a look at some of the biggest problems facing our world. I'm Maggie Fox. This podcast is brought to you by the One Health Trust, with bite-sized insights into ways to help address challenges such as pollution, climate change, and infectious diseases. A One Health approach recognizes that we're all in this together and that everything on this planet, the animals, plants and people, and the climate and environment are linked. Anyone who's ever listened to this podcast knows we talk a lot about antimicrobial resistance, the rise of bacteria, viruses, and other pathogens that defy the effects of antibiotics and other drugs. It's one of the scariest threats we face. Strep throat's a common childhood infection that's cured almost immediately with antibiotics, but imagine a world where strep throat can kill a child in days, or where a little cut can develop into a deadly infection, or where a standard hospital stay leads to an incurable illness. In this episode, we're chatting with Nour Shamas, a clinical pharmacist who's also an antimicrobial stewardship consultant for the World Health Organization based in Riyadh, Saudi Arabia. She's also a member of the WHO Task Force of AMR survivors. Nour knows about the need for better antibiotics, tests, and prevention, and not just through her job. She's got personal experience with drug-resistant infections, and she's here to tell us about what happened. Nour, thanks so much for joining us.
Thank you, Maggie, for having me.
Nour, first off, can you tell us a little bit about what you do as an antimicrobial stewardship consultant?
So basically, I try to bring together my experience as a clinical pharmacist in antimicrobial stewardship and resistance and my training in health policy or global health policy, try to figure out how can antimicrobial stewardship be made simple and easy to implement at the front line. And I just try to be creative and problem solve for different contexts.
And you're also a member of the WHO Task Force of AMR survivors. What is that?
That's a relatively new task force that tries to bring forward the voices of AMR survivors, people that have either survived antimicrobial resistant infections themselves or have taken care of patients who have had antimicrobial resistant infections. And the aim is to try to really show how difficult it is to deal with the resistant infections. It's not just one episode, it's often multiple episodes. Some people live with resistant infections for a very long time. They end up taking antibiotics for years on end and can be really detrimental to multiple layers of your life. So it's not just taking antibiotics. It's not just the price of the antibiotics or the availability, but it's also the side effects, the stigma that's related to it. So we all have different stories and we all try to advocate and talk about AMR from our perspectives.
So please tell us about your personal experience with this. Let's be clear, you live and work in Saudi Arabia, but you're from Lebanon and your mom in Lebanon got sick.
So, as you mentioned, I am an infectious disease clinical pharmacist in background. So I happened to be at a conference, an infectious disease conference at the time, and I got a call, and this is in 2018, saying that my mom needed emergency surgery. So since I wasn't there, my family took care of the situation. This was really significant spinal surgery. So a couple of months afterwards, she had started getting recurrent UTI. So she understands what urinary tract infection means, but it was really difficult for her to understand why she was getting it recurrently. So I tried to explain it to her, and she started taking IV antibiotics, intravenous antibiotics at home. We had to get a home healthcare nurse, which in Lebanon we had to pay for out of pocket. And finding the antibiotics on its own was really difficult. I sometimes had to bring the antibiotics from abroad, fly it into Lebanon for her. So it was really tough. And she's now very happy that I'm sharing her story. She wants everybody to know about urinary tract infections, that they're not a sexually transmitted disease, that women get more UTIs than others, and she's happy to be part of the story.
I think it's important for everybody to know what happened. Is she okay now?
She's okay now. She still gets UTIs. In fact, today she's gone to the clinic to get checked for one. She knows the symptoms now on her own. So it's something she lives with, but she's okay.
And can we talk a little bit about how you get urinary tract infections? I think she was worried. It sounds like she was worried about the stigma that people would think it was sexually transmitted.
Yeah, absolutely. Generally, urinary tract infections, especially in women, are not uncommon because of the physiology of the way that our body is built. Microbacteria can basically climb up through the urethra and create an infection locally that over time, if not treated, can ascend further up into the kidneys and can cause really significant harm. And even people die from UTIs, unfortunately. And so in my mom's situation, she had never had a UTI. Of course, she had had a UTI as a younger female, but at her age, she hadn't had UTIs till she went to the hospital, got a urinary catheter inserted for her surgery, which is normal. And of course, we expect hospital or acquired or associated infections for any hospital-related care. That's something as healthcare workers we accept and we explain it to patients. But in her situation, wasn't really defined as a catheter-associated infection or associated with her care because she got her UTI, let's say, 60 days after her surgery. So she couldn't really understand, why did she get this? And she was really worried about the stigma of having an infectious disease consultation on her file. Are people going to think she has a sexually transmitted disease? Because that's what ID or infectious disease is usually associated with. Took me a while to get her to an infectious disease consultant to come and see her to approve her medications. But it was really hard, and it's still hard for her to wrap her head around it.
Wow. And you just said something, you kind of threw it away, but we accept that you get hospital-acquired infections. Can we talk a little bit about that? You shouldn't go to the hospital and get something new there, right?
Absolutely. That's a really good point. We accept it. It's kind of like accepting, burnt toast. If you accept that, sometimes you're going to burn your toast, most of the times you're not. You put in some limitations to try not to, for that to happen. Of course, we're talking about a very serious situation here where people's lives get affected. And that's unfortunate because we treat it as though, as healthcare workers, it's kind of become normal, which is it's not great. I think epidemiologically, we just accept that it's likely to happen. And the likelihood that the patient will benefit from that intervention in the hospital is more important than the risk of getting the infection. But eventually it can be very hard on patients because, like you said, patients don't come into the hospital expecting to get worse outcomes afterwards.
And it sounds like it was really difficult to get the right drugs to treat your mother after she developed this infection.
Yeah, it was difficult. I don't know how much everybody is aware about Lebanon and what's happening in Lebanon, but the economic crisis and the economics in general impact healthcare. We know that politics impact healthcare. And so the situation currently is that a lot of the medications are not available or very inaccessible, either because they're physically not available or very expensive. In our situation, the antibiotic she needed was just not available for almost a year and a half. And we're very lucky. We're privileged because I'm working abroad, so I was able to bring in the antibiotic from outside. But most people aren't that privileged.
How much did you have to intervene? It sounds like you traveled, you went and got the antibiotics that she needed.
Yeah, I had to fly it in, and I still do every once in a while. I do exactly what I tell people not to do, which is don't buy an antibiotic before you actually need it. But in this situation, I buy it with a prescription just in case. My mom, of course, doesn't take it till she needs it, but because we have to prepare for it just in case it happens.
Can you tell us a little bit about the infection she has? It sounds like it must be a drug-resistant infection if it keeps coming back again and again.
Funny you say that. Actually, her infection is what I used to consider a not super important resistant infection. She had an extended spectrum beta-lactamase E. coli, so that's called an ESBL E. coli. So I, in my practice, used to think that's not such a big deal. But unfortunately, most of the antibiotics that treat this infection are intravenous. You have to take them through the blood. And so it's harder to get the antibiotics and they're not as available. On the other hand, with UTIs, and that's something that in general, that's true for all infections. Infections don't have to be resistant to be recurrent. So UTIs, you can get a recurrent UTI just from a simple E. coli, which is the most common pathogen for urinary tract infections. So even with the simple infections, relatively simple infections, we still have a problem, which is recurrence of UTIs. And that's what's so frustrating. That's something my mom asked me once. Why is it that as women, we know that women get more urinary tract infections than men, and it's more recurrent? And why is it so acceptable? And why do we have such bad antibiotics for our UTIs? She doesn't understand why we don't have more research going into the subject.
What do you tell her when she asks that?
The biggest problem is that, and just in general, there isn't enough investment into women-related healthcare issues. menopause, PCOS, or other menstruation related pain, or there are a lot of issues that we can hopefully fix for 50% of the world. But I don't know why there isn't enough funding into that. Maybe it's a matter of who funds, who is at the top of making these decisions. Maybe perhaps they tend to be men. Maybe they don't feel, and that's why it's so important to have a female presence in boardrooms, in meetings, but also as survivors, having people talk about the importance of investing more in women's health. And there's really interesting literature on this that's coming out more and more on the disparities between how likely, for example, is a woman to get an antibiotic if she walks into a clinic. How likely is it in the first place that women are exposed to infections? Like, who are the biggest portion of healthcare workers? They're women, nurses and pharmacists and physicians. And also, who tends to be the person going to collect water from different water holes, for example, or being exposed to taking care of an elderly person? They tend to be women. And so there's a lot of things to talk about in social structures and how that impacts women's risk to get infections and resistant infections particularly.
What do you want people to know or to understand about your experience?
I think first, it's really important for people to be medically literate, trying to educate patients early on before something happens. I don't think it's good to just wait till something happens to tell people about the risks or to explain to them what things are, especially if it's AMRs now all around us. For example, there's more education at elementary school level. Parents will end up picking up on these issues. It's maybe an easy way to increase medical literacy around AMR. It's not easy, but potential way. So the reason for that is because my mom had spoken to me so much about antimicrobial resistance before she had her infection. I think it made it easier for her to accept it and to understand it, as hard as it was. And for her to accept that she's going to have to take an antibiotic 3-4 times a year for an infection that just won't go away. That's number one. Maybe the other thing that's really important is access to antibiotics. Shouldn't be a luxury. It's a healthcare right. It's a right to have access to antibiotics. And there are so many politics around that when it comes to price of antibiotics, the availability, who buys the bulk of the antibiotics and how it's distributed. And I think people really need to focus on these points if AMR is to be tackled, and diagnostics, of course. I'll just add that we are very lucky because we went to a specific hospital. We're lucky to have the finances to cover it, where they can actually test for the susceptibility of to identify the pathogen. Whereas a lot of people don't have that as well. You just don't know what you're treating. So you just give random antibiotics till, the patient gets better or maybe not get better at all.
It must have helped your mother a lot to have a daughter who's an actual expert.
We're very blessed and I'm happy that I could help her with it. But it also makes me feel very frustrated to imagine what it's like for people who don't have that care, who don't have access to this information and how to deal with such a common infection.
What would you advise someone who's in a similar situation that doesn't have a daughter who's an expert?
I would hope that the local community pharmacists and physicians would be aware about how to help them manage the infection. And that's why I think we have a responsibility to make sure that people are trained and to stop thinking of hierarchies in healthcare delivery when it comes to prescribers and pharmacists that are dispensers, and try to make sure that people are all aware of how to manage antimicrobial resistance. So that, just as you said, if someone doesn't have access to an infectious disease specialist, they still get the same care.
How did this near disaster, it really was almost a disaster for your mother, how did it affect how you approach your work?
It made me think twice before either suggesting an antibiotic in a clinical setting or stopping the antibiotic or changing the antibiotic. I used to be a lot more naive about reducing how strong the antibiotic is. So we used to switch from a stronger to narrow spectrum, what we call a narrow spectrum antibiotic, let's say a day 3 and 4. So I'm a bit more careful when I do that. And at the same time, I'm a lot more careful when I start an antibiotic to make sure the patient understands what they have, why they're taking the antibiotic, what is the likelihood that this infection is going to recur, what can they do to avoid it recurring, and what is a microbiome, which is the gut typical bacteria, how can they replenish it. So I think it's made me a lot more approach it with a different lens where I can talk to the patients a lot more.
Is your mom taking care of her microbiome?
She is, yes. In Lebanon, we eat a lot of yogurt and lebne, which is full of good bacteria. I think she's learned that this is going to be part of her diet forever, and she's happy to do it. But I think that very often a lot of cultures don't have yogurt and culture-rich food in their regular diet. So I think it's important to talk about it.
Nour, thanks so much for joining us and for sharing this story with us.
Thank you, Maggie. I'm happy to be here.
Listeners, if you enjoyed this podcast, please share it. You can learn more about this podcast and other important topics at onehealthtrust.org. And let us know what else you'd like to hear about at owh@onehealthtrust.org. Thanks for joining us.
Thank you for listening to One World, One Health, brought to you by the One Health Trust. I'm Ramanan Lakshminarayan, founder and president of the One Health Trust. You can subscribe to One World, One Health on Spotify, Apple Podcasts, or wherever you listen to podcasts. Follow us on social media at One Health Trust, one word, for updates on One World, One Health and the latest in research on One Health issues like drug resistance, disease spillovers, and the social determinants of health. Finally, please do consider donating to the One Health Trust to support this podcast and other initiatives and research that help us promote health and well-being worldwide. Until next time.